Hassan. Alright guys, today, welcome first of all. We've got Hassan Magaireh from Leeds. He is a implant surgeon. He does teaching and speaking with the British Academy of Restorative Dentistry. That's BAI, British Academy of Implant and Restorative Dentistry, BAIRD. And we've got a really interesting case lined up for you guys. I'm just going to see if Hassan has already joined us, which he has. Awesome. So yeah, who knows how you guys are doing at the moment. Coming up to the end of Ramadan, so Eid's coming, so that's going to be fun. Well, what else have you guys been up to? Hey man.
Hello, how are you doing?
Good, thank you. How are you?
Good to see you, Jabbar. How are you?
Yeah, good. Possibly Eid tomorrow. This is what we're waiting to find out.
I think it's confirmed, right?
I think so.
Yeah,
we're on the 29th.
because we've done the 30 days by today, so.
Yeah, some people started one day after, so
okay.
that could be it, but we're going to find out, so it's all good. Guys in the comments, how are you all doing? Dr. Hassan, do you want to tell us a little bit about how you kind of got to this point in your career, very briefly, and because we've got a really juicy case, which I think we want to take up some time talking about, but just so the guys who don't know already who you are can understand a bit about what you do and what they can benefit from you.
Well, good evening, everyone, and good morning for those watching us from the States. It's really nice to be here today. Thank you for your kind invitation to be at Dentist of Insta. So I'm Hassan. My parents originally come from Jordan, and I grew up in Jordan, in Amman, the capital of Jordan. I did my high school over there, and then from there I went to Cairo University in Egypt to do my undergrad dentistry. And immediately from Egypt, I flew to UK to start my oral surgery maxillofacial training. So I joined the maxillofacial unit at the Humberside, which is East Yorkshire, Hull, Scunthorpe, Grimsby, not far from you. And I worked in oral surgery for about 5 years, which I did, my senior house officer jobs, my Royal College exams, and then I did my middle grade job, which is basically staff grade job at Wakefield, Penderfield Hospital in Wakefield.
Yeah.
But then I started missing dentistry. So I thought, you know what, it's time to come back to dentistry because, working at a hospital is great. And you have to be really focus at what you're doing. And I just did not fancy these long operations, like 12-hour operation.
Yeah.
It was a bit too stressful. And it's sad because in UK hospitals, as we all know, they're always understaffed, everyone under pressure. And I realized, you know what, this is not my passion. I have to pursue my passion. So I joined the master's degree in implant dentistry at the University of Manchester back in 2006.
Okay, nice.
And I had fantastic 2 tutors, Marco Esposito, who's like the worldwide father of evidence-based implant dentistry. He's done loads of random control trials, systematic reviews, was editor of the European Journal of Oral Implantology, and now he started his new journal, which is an amazing journal called Clinical Trials in Dentistry. So it's to do with everything in dentistry, not only implant dentistry. And then I've got another good oral surgeon, you might know him, Paul Coulthard, and he was a really good oral surgeon. And, together with another third guy, I would really like to mention Jonathan Rees, who's a very good implantologist in Chester area. He was my mentor at the time. So I did my master's degree, and from there, I've been limiting my practice into implant dentistry. But let me tell you a little secret. The science and the knowledge I had at my master's wasn't good enough for me to pursue a successful career in private implant dentistry.
Right.
And if I look at my cases I had back in 2007 and 8, it was mainly focused on the old school, follow the bone.
Yeah.
And it was around 2010 when I started through Marco, have some connection with Italy, attend more courses in Italy. And that's when I realized there is something called aesthetic or cosmetic implant dentistry. It's all about the soft tissue. And that was the switch. It was a total switch, I would say 180-degree switch of the philosophy, the way you think, the way you plan, the target. You know, they say, as a dentist, whenever we have a case, we go through 3 stages. Okay? Yeah. We go through the diagnosis, and we go through the treatment, the choice of treatment, the technique, and then the outcome. We all agree on the diagnosis, but the main secret is to try to focus on your outcome. My outcome, or desired outcome in 2007, is completely different to my desired outcome in 2010. Because all of a sudden, I started to realize this wasn't good enough, just having an integrated implant. Yeah. And I think nowadays, everyone share this view. You know, we know, as Urs Belzer, a famous prosthodontist from Switzerland, he says, it's all about the pink. Because if you get good pink aesthetics, white aesthetics become easy. Yeah. If the pink fails, even having the best ceramist will not give you good white. So in implant dentistry, it's all about the pink integration. And not only that, maintaining that pink integration. And that's what changed my job, like completely 180 degrees, into trying to produce something which mimic nature.
Yeah. I think that makes sense, because patients want something that looks natural. They don't want a really long central incisor. True. Or a really funny, blocky looking effect, which sometimes if you're just going, I want to make something which is functional and it's going to stay there, then you'll get that. But you need to plan.
But you know what? It's not only that. You know, if you think about it, why do we do bone grafting, for example, right? You know, we do bone graft around an implant to protect the implant, because we know if we have less than 2 millimeter bone thickness, bone will shrink, right? So whenever you have an implant case like this, you put the implant in the right position, okay, within the prosthetic envelope, and you get some dehiscence. So you need to do bone grafting. But then there is another reason for bone grafting. Call it level 2 understanding, is to try to graft the area to get that nice ridge contouring, because that convexity, it's what gonna give you that natural appearance, right? And that convexity is what gonna stop the gum shrinking and having this very long central incisor. But then there is a third reason. We do bone grafting even for molar implants where aesthetics is not an issue. Because if you have a narrow ridge and you put a big molar on top of it, you're going to have that buccal undercut where food and plaque going to be trapped there. Going to be nightmare to clean. And if your lab technician trying to play clever, I don't want, you know, he doesn't want to give us an undercut. He will give us a ridge lap, which looks amazing, but it's going to be food trap. So you're going to find Nando's, Domino's, everything there, pizza stuff underneath that ridge lap. So that's why even nowadays in the molar region, we most likely have to bulk that ridge again to the normal size if we're going to give a normal size molar, make it a hygienic restoration. So that's the idea. You know, we do GPR to protect the implant, to get some good ridge contouring for aesthetics, and to get ridge contouring to be able to produce a hygienic prosthetic design.
Yeah, I think that makes sense. As someone who doesn't place implants, I think I was able to follow that as well.
So, you are an endodontist, aren't you? You're into endo.
Yeah, I'm into the endo side in the future, hopefully. The case that we've got today, so the first few slides you just sent me, what was going on in this case? I think you posted this as a page post just recently, right?
Yes, I think this is a case. Well, actually, he's someone who's seen me about seven years ago. So we have now 7-year follow-up of this case.
Okay.
And this is a guy who lost two front teeth, missing central and lateral. Now, the question is, are we going to need 2 implants to replace 2 missing teeth? Or can we go for a cantilever option? And sometimes we do that. We cantilever the lateral of the central. And it's all about bone analysis. You need to understand there are certain limits, how close you can be to the adjacent teeth. And more importantly, what's the distance between 2 implants? Now, after you do your space analysis, we know we need minimum of 1.5 millimeter away from the root. And that's minimum. If you can do better, even greater.
Yeah.
But between the 2 implants, studies show minimum of 3, even better 4 millimeter. Now, why is that? Because we know now there is direct relationship between the vertical height of that triangle between the 2 implants and the base, the length or the distance at the base. The longer the base, the more blood supply you're going to get to that area. And that means vertical stability. Now, why is that peak is important? Because that peak is going to maintain the interdental implant, the interdental papilla between the 2 implants. We know now from loads of studies, and they're not recent, we're talking about late 90s, that the papilla, whether we're going to have it or not, depends on the distance between that bony peak and the contact point of the future restorations. And people whenever you ask that question, people always refer to Dennis Tarno's work and they say 5 millimeter is the magic number. But that's what happens when you read the conclusion of the study rather than reading the methodology and the result. 5 millimeter is the right number when you have 2 adjacent teeth. If you have 2 implants, it's 3.5. So if you have 5 millimeters vertical space between the crest and the contact point, you're going to have black triangle. So it's important to maintain that peak. And how do we maintain it? By maintaining the base. Now, how do we do that? By sometimes going for 1 implant rather than 2 implants, or by going for 2 narrow implants. Now, that's a completely different story I'd like to touch on. Going for narrow implants, can we trust them? Now, historical studies show that we get more implant fracture in the anterior region if we have an implant less than 3.75 diameter. So most of the fracture in the implants, imagine these implants are implants with internal connection. So they're hollow from inside, right? So most of the fractures happens when you get 3.5 or 3.0 implant. But how can we use narrow implants? This is where the new technology kicked in. We're now using titanium grade 5, which are titanium alloys, which makes the implants harder. Now, titanium grade 5 means less pure titanium. So there was always a question about the biocompatibility of these implants.
Yeah.
But there are some implants in the market where they said, right, what's the most biocompatible metal? It's zirconia. If we mix it with titanium, that makes the alloy double the strength. We call it rock solid alloy. And hence, we can get away, like in this case, 3.3 millimeter diameter implant for central incisor and for a lateral. Now that will mean having bigger space between the 2 implants. Now that's the mesodistal analysis. Now what about the depth? How deep we're going to place these implants? And again, this is biology-based decision. It's all about the biological width. Now we understand in natural teeth, Jabbar, that biological width going to be about what? 2 millimeter, 2 to 3 millimeter? And biological width is something you measure from the base of the sulcus to take in consideration the length of the junctional epithelium and the connective tissue underneath, so to the bone level. Now, when it comes to implants, we don't have the luxury of a sulcus. There is no sulcus, okay? It's a continuous pseudo pocket. So in implant dentistry, the biological width being found to be 3 to 4 millimeter.
Yeah.
Now, if you remember, for crown and bridge work, if you invade the biological width, you're going to have some reaction. If you get thin biotype, that gum will recede, and hence you get exposed margins. If you have thick biotype, you're not going to get gum recession, but you're going to get bone shrinking, creating pockets, inflammation, right? Now, the same thing happens with implants. If you place the implant too shallow, you're invading the biological width from the back entrance, and the gum won't like it. And then the bone will say, right gum, you're inflamed, you're annoyed. I'm going to do something about this. I'm going to shrink away from you. And that will cause bone loss around the implants. Now, what if you place the implant too deep? The gum will say, wow, the bone is too far from me. Ideally, I want the bone to be maximum 3 to 4 millimeter away from the gum margin. If the implant is placed too deep, the bone will remodel to the margin of the implant. That gum might be 6 millimeter thickness, for example, and the gum won't like it. So it will shrink to re-establish the biological width. So that's where we decide where to place our implant, depth-wise.
Yeah.
Now, the problem, when you place an implant subcrestally below the bone level, it becomes an issue because we know the connection between the implant and the abutment, like it or not, gonna have a micro gap. And this micro gap will be filled with bacteria. And what goes in will go out. So this bacteria are going to start acting as a spray effect, causing some bone loss. Hence, whenever you want to go for aesthetic implants, which means sometimes subcrystal, you really need to focus on the type of your implant. And that's the question I always get asked by my junior colleagues. Does it really make a difference to go for a premium or a cheaper implant? And the difference, believe it or not, is not in the surface, because all implants will osseointegrate. The challenge is in the connection, because that connection and how tight is that seal will make a huge difference whether we can maintain the bone or we're going to lose it quickly. So it is important to have a good seal. And, you're not going to get 100% seal, but as tight as possible. And you get this when you have an implant system with a good internal connection design.
Yeah.
The final issue we have to talk about, the apicocoronal thickness, is, you need to understand that the bone will remodel to the level of the thread, keeping the thickness of the gum above it. We know from the zero bone loss concept, that we need to have a minimum of 3 millimeter gum thickness above the bone. Otherwise, as I said, biological width will kick in and will give us bone loss. If you're going to have to place a shallow implant, you need to do something about increasing the thickness of the gum above the implant margin. Whether you're going to do it surgically by soft tissue grafting or by going for prosthetic soft tissue management, such as putting a healing abutment, cover the flap on the top of the healing abutment, creating a dead space which will be filled with granulation tissue, and without even doing any surgery, that tenting effect, I call it the umbrella effect, it's going to increase the thickness of your soft tissue.
Right. Very clever, that. Yeah.
Now, last but not least, we talked about the mesiodistal, we talked about the coronoapical. Now, the point where people get it really wrong is the buccolingual. It's so easy to angulate the apex of the implant into the palate, so the shoulder of the implant comes towards the labial surface. Yep. Now, let's remember, my friends, that labial bone is made of cortical bone. And bone biology tells us that while cancellous bone loves compression, because compression gives you remodeling, cortical bone cannot be touched. You touch it with very little force, it's going to shrink. And that's another reason for people having that long central incisal effect. So buccal position of the implant can control the future aesthetic result. Ideally, you want the shoulder of the implant to be away from the labial plate, to protect the labial plate, but also to create a space for the future guided bone regeneration to go for. Because if the implant is where the bone needs to be, the bone's going to be where the soft tissue needs to be, the soft tissue will have no place and will start to shrink. Hence, you could see it's like dominoes effect. It's so important. Planning, planning, planning. But planning with a philosophy, with a mentality, wanting to have an aesthetic outcome rather than just an integrated implant as our outcome.
Yeah, I think it makes total sense that you have to, same as within any kind of level of dentistry, one mistake early on will have so many knock-on effects as you go down the line, whether it's ledging in an endo, meaning you can't then recapture the apex. It could be any one of these things, and it's the same within implants, of course.
True. I think what makes, I always get asked, what makes you a good, or what makes someone a good implant dentist? And I strongly believe whether you're an implant dentist or whether you're endodontist, whether you're prosthodontist, there isn't a bad dentist. Every dentist been through dental school worked really hard to get his or her dental degree. But what happens as people go into the dental offices and dental practices, people sometimes lose their passion. So the difference between a successful and non-successful dentist is how passionate you are. Because what's the opposite to passion, Jabbar? What do you think?
Just letting things go, letting things, cutting corners, letting things slide.
Exactly. Indifferent.
Yeah.
I don't care. That's it. You're either passionate or indifferent. People really don't care whether they're going to do endo with a rubber band or not, rubber dam or not, whether they're going to do composite with good isolation. They don't care. Patient won't find till later on. But it's all about you as a person, how passionate you're going to be. And only that going to make you successful.
Yeah.
Now, the trick is, if you speak, usually, as a dentist, you go as a dental student, you finish your dental degree, you go out, and most of the people around you will have lost that passion. So then you don't have a good sort of mentors or good example, and gradually you lose your passion. That's why another secret for success is the moment you finish your dental school, you need to link yourself to a good group. Because only then having a good mentor, passionate peer, and passionate colleagues, they're going to pull you up rather than push you down. And that's another advice I would like to give to my colleagues. We never stop learning. I'm sure you and me and so many of our colleagues watching who've been during this lockdown watching lots of webinars to develop ourselves. And hopefully we're going to come out of this lockdown better than we were back in February.
Yeah.
So it's all about us being passionate, wanting to develop, but having good surrounding, good environment will also control how good we're going to be in the near future.
I think it's the same concept. There's the old saying that goes, you're the average of your three, best friends or the three people closest to you.
I like that.
If you're the one dragging people up, then actually you're probably just going to get bogged down a little bit. So you want to kind of associate yourself with those guys who are trying to push the limits and push the boundaries, or are just active in whichever career they're in. So it doesn't have to be always you're friends with another dentist who's doing really well. It could be a lawyer, it could be somebody else, but somebody who's pushing the career, so then you have the desire to push your career as well.
True, because it's all about the mentality. It's all about having that right, and then these will be easy to make them go well.
To come through. Should we have a look at the next picture?
Yes.
So quickly, this was was it to kind of show the three concepts we were talking about: buccal, lingual, mesiodistal, and then the depth of the implant.
And showing how we can create a papilla in between the two implants, you know, easily if we follow the system. Now, this is the same case, but from an occlusal view, to show you why, when we started, we had buccal bone loss. Now, why do we get buccal bone loss whenever we have a tooth out? So many reasons. Now, the average thickness of a labial plate in the anterior region, in 87% of the cases, being found to be less than 1 millimeter. Okay, that's biology fact number one. Biology fact number two, that the first layer of bone lining the socket is called bundle bone. And that bundle bone getting its blood supply from the periodontal ligaments attached to the tooth. The moment you take a tooth out, you basically you disturb and disrupt the periodontal ligaments blood supply coming to the labial bone, and hence you get labial bone loss. And number three is you and me. Taking teeth out, being in a rush. You know, I remember, I'm surely nowadays they've changed the teaching, but I remember when I was at my dental school, they used to teach us go buccal lingual movement to expand the socket and then take a tooth out. Nowadays, this is totally unacceptable. We need to go more rotation, anti-rotation, rotation, anti-rotation. Even before taking a tooth out, think about how would this tooth come out without disturbing the labial plate? Because when you do the buccal lingual, basically you're leaning on the buccal plate and you're going to take it out, which will complicate any future case, whether it's implant or even conventional crown and bridge. So rotation, anti-rotation. And sometimes you might need to think, right, what's holding this tooth in place? Periodontal ligaments. So maybe get your 15C blade and cut these periodontal ligaments before you start your rotation, anti-rotation. So you go in the sort of sulcus mesially, distally, palatally, and then gradually, you know, incise these ligaments, and that will make the tooth out coming out easily. I would do this for anteriors and for premolars. Now, what about molars? Section that molar into 3 roots, and then you will deal with that molar. Is made of 3 small anterior teeth, and they'll come out easily. If you do that, you're going to preserve the labial plate. Yeah. Yeah, true. Another reason for losing the labial plate, sometimes failing post crowns. When you have a failing post crown, most likely, if you check carefully, you're going to find a vertical crack within the root. And you're going to have bone loss to the depth of that vertical crack. So whenever you get a failing post crown, please have a good look. Rather than just re-cementing it, you know, you're not doing your patient a favor by just re-cementing that post crown back without looking carefully. Because if there is a vertical crack, the earlier you take this tooth out, the better. And finally, if you find there is, after taking a tooth out, there is a slight bone loss or the labial plate is very thin, that's what you need to do.
Somewhere, guys, so if you have a look, this was a failing post crown that I've seen. So you can see that, I mean, this is a really obvious one. So I think that just demonstrates your point perfectly. There's going to be some bone loss down to that level.
Beautiful. Now, excellent. Now, even deeper, because that crack would have spread even deeper, maybe to the middle of middle third. Exactly.
Yeah, that was a real big one.
So the other point I wanted to mention here, whenever you want to take a tooth out, you need to, and I think we all do it, talk to the patient. You're going to lose a tooth now. What are you planning to do later on? You're not going to have that gap, okay? Now, if the patient said they're going to have a conventional bridge or an implant, think about ridge preservation. Because if the patient going to have a conventional bridge and this area going to be pontic, if you do nothing, you're going to get 50% buccal lingual bone loss within the first 24 weeks.
Yeah.
And imagine having that pontic with no bone underneath. It's either going to be food trap, or your lab technician has to give you an ugly ridge lab design. So sometimes just going for ridge preservation, which means trying to put bone material into the socket to slow down the remodeling. And studies show, for example, if we use xenograft, which is bone comes from animals, cow bone, you're going to have that bone loss going from 2.5 or 2.6 if you do nothing to 0.3. So you could see the difference. But if you're going to place an implant, then you ask your patient how soon you're going to go for that implant. If they tell you they're going to go for an implant within the next 8-12 weeks, blood clot will be the best thing to do. Do nothing. But if they say they're going to start saving up for an implant, or they're having some exams or some business stopping them coming back in 8 weeks to have an implant, I would urge you to consider ridge preservation. So which bone material we're going to use here? The decision needs to be biology based rather than market oriented. And what do I mean by that? Your bone material in the market, you're going to have different choices. You could have xenograft, which is animal origin, or you could have allograft, which is taken from the human tissue bank, and nowadays from live donors, not dead people. Or you could have alloplast, which is purely made in the lab, purely synthetic.
Yeah.
Now, which one we're going to go for out of these three? You need to understand two concepts. The first concept, Jabbar, that whenever we put bone material in a socket, after 24 weeks, we're going to have three different components in that socket. 1/3 or some of it will become a new vital bond, which is great. This is what we want to achieve. And the other will be remnants of the bone material which has failed to integrate and failed to remodel, and might with time remodel or might go necrotic. And the third component will be connective tissue in between these bony particles. Now, that's the first concept. The second concept we need to understand whenever we want to choose which bone material I'm going to use, that we need to understand that one size doesn't fit all. And different bone materials remodel at different speed. For example, xenograft has been shown that after 24 weeks will remodel by 12% if you're lucky into new bone, while allograft to 60% and alloplast similar. But what about stability? Now, the ones which remodel quickly are going to lose bone volume quickly. So if the patient comes to me and say, right, I'm going to come back after 1 year to have my implant, putting alloplast or allograft will be waste of your time and money because that bone will be nothing after 1 year.
Yeah.
Then you need to go for xenograft, because xenograft will maintain the volume a long time, and you're not going to go for an implant while there's still 12% because that's 6 months. But if the patient comes to you and say, right, I just need 24 weeks and come back and have my implant, then putting xenograft would be the wrong choice, because after 24 weeks, you're going to put your implant in cow bone, which has only converted 12% of it into natural bone. So then my choices would be alloplast or allograft. So it's all about biology. It's all about understanding the biology. I really feel sad when I see some of my colleagues choosing their bone material according to the market, or according to what the cheapest bone available in the market, or who's got the best offers, buy 5 and get 1 free. It has to be biology based. You know, you and I aim for patient outcomes to be positive. And to do that, it's either biology based and evidence based together going to give you that positive patient outcome.
Yeah. You've got to start with the end in mind. And if things line up, then great. in terms of someone has an offer on an allograft and you were planning on using an allograft because biology went that way, then perfect. But otherwise, you haven't got a leg to stand on from my point of view. If you are doing the same thing with it, again, within every part of dentistry, if you're using the things for the wrong reasons or because it's cheap, because it's easier for you, then the end result's going to be compromised. If the patient finds out, you've got no recourse.
The thing is, it's just like endo. You can never do all your endo using one file. I don't know. Can you do that?
No.
Okay. So the same thing, you have to have different bone graft in your cupboard, as well as, believe it or not, different implant designs. You know, companies should be competing on us rather than us competing on them. They should be providing range of products to fulfill our cases, because you know, the patient I see on Monday gonna have complete different case scenario to the patient I'm gonna see on Tuesday and Wednesday and so on. It's all about diagnosis. At the very beginning, we said diagnosis and then what chosen outcome. Now, whatever you do in the middle should be controlled by these two major factors: diagnosis and my chosen outcome.
Yeah, I think that makes total sense. And then you can see within this case, this is the same case, was it not?
Yes.
The end result, you couldn't tell that these were not.
It is acceptable, and these are 5 years post-operative. I think the good thing, I'm looking here at the stability of the bone, stability of the gum, and we, you know, following the biology, understanding, evidence-based, as a team, we managed to do this.
Yeah.
What I meant by as a team, I'm blessed that I work in a small team. When I say team, it doesn't have to be a huge team. You know, I work team of 3. Me, my restorative dentist, Victoria, who's a fantastic implant dentist, but she also does the restorative work with me, and my implant coordinator. You know, I heard you yesterday talking about 600 dentistry. This is what we do in our practice. We all, the 3 of us, are there to make our patients' life easier and make our work better. And that's how we achieve even good level photography. You cannot, as a dentist, you know, do good photos and work at the same time. You have to invest in educating your team and investing in your team to work together, the 3 of us. You know, sometimes Victoria will do the surgical case and I will be taking photos. And other times I will be doing the surgical, Victoria do the restorative, and Laura, the nurse, the implant coordinator, will be taking photos. So the 3 of us work together as a team.
Yeah.
And that's another advice, you know, talking about being successful. You really need to look after your team, invest in your team as much as you can.
Yeah, I agree completely. Dr. Reza's had a quick question for us here. Did you do some temporization within this?
100%, 100%. You know, this is a concept we are 100% following, prosthetic soft tissue sculpture. And this is something, again, Victoria has a special interest in, and she lectures for the ITI on this topic. But to summarize it, the difference between going from a healing abutment to a final tooth, that when you get that final tooth with, let's say, triangle cross-section, you're going to squeeze it into that little circle, which is the cross-section of the healing abutment. And that will put pressure. Now, if you have thin biotype, you're going to get recession big time. If you get thick biotype, you might get lucky. But the prosthetic soft tissue sculpture, you start with a temporary crown with a circle cross-section, and every 2-3 weeks, you take it out and add some highly polished flowable composite. So what you do, you put a controlled level of pressure, and that contours the emergence profile, but not by necrotizing the tissue, by displacing the tissue. So if you go back to the photo before, please, you could see using these temporaries, not only we managed to get a good emergence profile, but we displace the tissue. And that's another example of prosthetic soft tissue sculpture, building the soft tissue without surgery. So definitely all our anterior cases, it's a system. all our anterior cases, premolar to premolar, will go through a temporary crown stage. Now that's extra cost, Jabbar. And I have to be honest with you, some patients can be, it's all about communication and education. The way we sell it, we say, right, temporary crowns can be important for prosthetic soft tissue sculpture. Let's say some of the patients will get the idea and some of them won't. Then we go on and say, temporary crowns are good test drives. So your front anterior tooth, when we have a temporary crown, you can check whether you want a diastema or not, whether you want it white or not, whether you want that angle to be contoured, so you don't get surprised at the final restoration.
Yeah.
Most people will get it, but then there is a third reason, which usually, when we sell the implant temporary crowns, patients love it. We go to them and say, believe it or not, this final implant crown is not for life. And there will be time when this final implant crown gonna crack. Now, would you rather me take this final crown, send it to the lab for repair, and you bounce back to your denture? Or would you rather bouncing back to the temporary crown, which you already paid for long time ago? And that's how our patients tend to say, yes, let's go for temporary crowns. We'll pay the extra for the temporary crowns.
Yeah, that's a nice little trick to get them on board there. It's almost in my head like ortho for the gums. Just
Perfect.
Slowly moving it around.
Well, the beauty, you're not only shaping it, but as you said, we're bulking it, we're moving it as well. Gradual. And that's right. Ortho for, I like that. I'm going to start using this, Jabbar. Ortho for the gum.
It just, because you were starting to add in, you know, little bits of composite, I was like, this sounds like Invisalign, but it's underneath and it's moving things. Yeah. That's a really, really good case. Shall we move on to the next one? So this one here,
yes,
you sent me a while back.
Yeah, this is, you know, when we were talking about bone grafting and implant dentistry, guided bone regeneration. Now, we need to understand that the whole concept of guided bone regeneration is actually about the membrane rather than the bony particles underneath. Now, let's understand one biology fact. Whenever we have a gap in our human body, there will be cells competing to fill this gap. Now, for our bad luck, when it comes to bone grafting, the bone cells are the lazy cells, while the fibroblasts are the active cells. And that's why if someone break their lower jaw and they do nothing about it, they're going to get fibrous union rather than bone union. So bone cells are lazy and they need lots of activation. And at the same time, we have to do something to keep this fibroblast far away. And that's where the membrane is important. So this membrane acting as a barrier. And the whole idea of GBR, which is, I'd like to call it the younger brother of GTR, guided tissue regeneration for infrabony defects in perio. So you need to have a secluded space. So you know perio infrabony defect, what do? Root planning, clean the area, make sure you've got a blood clot, isolated. So you have a secluded space covered with a good barrier, right? Stopping fibroblasts coming into the space, allowing bone cells to start to fill that space for you. So the same thing happens with guided bone regeneration. You have to have a good membrane containing the particles underneath. Now, for that to work well, that membrane needs to be well stabilized. If you can have a barrier, that barrier needs to be well stabilized, well fitted. And sometimes we use these 3mm titanium pins, which can be easily removed because they're polished, they're not going to integrate into the bone. Or sometimes we can suture the membrane. Now, when it comes to membrane, there are different membranes in the market. Personally, I like the membrane which is stretchable. In this case, it's Jason from Botis, which is a very good German company, and they have a range of products, bone and membranes. But I also like it, you can put a needle in it, and suture it without tearing it. So because it comes from the pericardium, which is full of collagen, dense collagen fibers. So you could put a needle with it without tearing it that easy. It doesn't need high skills, I promise you.
Yeah.
You know, it looks like complicated. This is the stuff we teach our junior colleagues at the Bird Academy course, and they do it perfectly well. It's a system you follow. You just need to see it, practice it on animal heads in workshop, and they're easy to use. If anything, stabilizing the membrane makes the GBR much, much easier. And I promise you, if you're going to do everything following the system, you're going to get predictable results every time.
Yeah.
But there are certain things you have to learn, because repeating the same wrong technique 100 times doesn't make it any better.
Yeah.
So I promise it's an easy technique, but you need to know, you need to see how we do it.
Yeah, I think it's the same as, again, if you remember back all those years before you went into university, could you imagine, okay, Hassan, you know, first day, go and do me a root canal, go and do me a filling. You haven't got a clue. You need to be shown the same way, step A, B, C, D, E, final result.
And if I may say, you know, building on your point, this is the importance of continual education. You know, as a dental student, you leave dental school knowing little thing about so many things. And ideally, you need to work for a while with a mentor, develop a passion towards something, and then pursue a successful career in that something. Now, how to do that successful career, as you and I mentioned earlier on, surround yourself with high-level people, find a mentor, and never give up on investing in education.
Yeah.
And that's what we do in our Bird Academy, the British Academy Implant Restorative Dentistry, which is based in Leeds. And we've been running these one-year courses for 10 years so far. And on this course, it's like 8 modules, each module made of 3 days, Friday, Saturday, Sunday. So altogether 24 days, Jabbar.
Yeah.
And the beauty, not only we get evidence-based and biology-based and clinical seminars, hands-on workshops, because we have different speakers every module. So we have the best perio, the best proslo, the best occlusion. But we also provide our younger colleagues or our colleagues with patients. They treat under our direct supervision during the course. So they don't need to worry about finding a patient. They don't need to worry about covering extra cost. And their first implant case is going to be me or one of my senior mentors standing behind their shoulder, looking at them, making sure they're doing the right thing from the very beginning. Now, this is what I didn't have. When I started my master's, I didn't have that mentor who can stand behind my back and showing it to me. And I had to learn it the hard way. And that's why I made a decision when it comes to investing in education. I have a duty towards my colleagues to make sure they learn the right thing from the beginning and learn from my mistakes rather than having to go through their own mistakes.
The same again. Tahir's got us a couple of questions, so I'll shoot off these. The first one is saying, what do you think about corticobasal implantology with smooth surface instead of all these surgeries? I think these are more kind of from the 80s and the 50s.
Basal implants, they're coming back. Now, I would say to Tahir and all my colleagues who use these implants, what's your chosen outcome? Is your chosen outcome aesthetic implant dentistry? Then these implants are not the right implants for you. Is your chosen outcome having a minimally invasive surgery in someone with atrophic ridge without needing to worry about bone grafting? They might work, although I have my own reservations because you're going to have a full arch cemented. And we know we don't like that because we're talking about how, regular maintenance is important. Now, regular maintenance for a full arch case means removing the bridge, cleaning underneath, and putting it back. And that's why it's important to be screw retained.
Yeah.
Now, if you're talking about good emergence profile, these basal implants are not the right choice for you because they all have narrow emergence profile. So you're going to have a big molar on a very narrow abutment. And that will give you what we call the potato on a stick effect. Food going to get trapped, plaque going to be nightmare to clean, and going to be harder for the patient to keep it clean.
Yeah. I think there was also, I was reading a long time ago that there is a association between cement retained implantology work and periodontitis as opposed to using screw retained. I can't
100%.
remember
This
the
is
study
true.
in my head.
Yeah, this is the truth from Thomas Linkovic from Lithuania.
Yeah.
Basically, what they found, higher risk of periimplantitis with cement retained restoration compared to screw retained restoration. We're talking about 87% more. We're not talking about like 10 or 20 or 30. Because think about biology, Jabbar. A natural tooth will have that good sulcus around it, right?
Yeah.
And that sulcus have lots of dense connective periodontal ligaments and connective tissue underneath, right? So as you put cement on your crown, go on a natural tooth, the cement going to go into the sulcus, you're going to find a sealed base and flow up. While with an implant, that sulcus doesn't exist. No. It's a free gate all the way towards the bone. So you put cement going to be pushed down to the bone, acting as a foreign body, trigger bone loss, periimplantitis.
Yeah.
That's why nowadays, successful implant practices in UK, let me say that, they're shifted to screw retained. Now, sometimes we end with cement retained, but that's going to be our plan B, not our plan A.
Yeah.
And if we're going to do that, we're going to have a properly designed CAD-CAM abutments with wide bays. And you, with the CAD-CAM abutment, you design where the finish line going to be. So palatally, we go equigingival.
Yeah.
Labially, 1 millimeter subgingival. Mesodistally, 0.5 millimeter subgingival. So removing excess cement going to be easy. Going to the basal implants, you're going to have big restorations on a very narrow abutment. It's going to be recipe to disaster when it comes to good oral health. Well, at least this is what I've seen from others. I've never used them. And I respect there are always going to be people who are passionate about what they're doing, and they're going to do good work regardless what they're going to use.
Yeah, I think that's true. And then this is a nice showing us the couple of different membrane, the grafts. So
yes, it shows how we stabilize the membrane with the pins and then lift it back like a curtain. And then the first layer of bone, we like it to be autogenous. And because we want to have natural bone on the implant surface. Now, if the defect is too big and you don't want to put your patient through the trauma of harvesting autogenous, we can use allograft, because allograft is the nearest when it comes to remodeling to autogenous. But then the second layer, which is all about the contouring and the stability of that convexity, we use it as xenograft. And this is what I call it the layering technique. Now, if people would like to know more about it, they can visit my Instagram profile, because 3-4 weeks ago, I posted 7 tips in guided bone regeneration. Every day there was a tip, a picture, and lots of information. They can go and read about it.
Yeah.
And hopefully soon, I'm in the middle of preparing similar series, 7 tips in restorative implant dentistry. So hopefully it will come out very soon.
Yeah, I don't think we're going to get around onto the CAD-CAM today. We've got about 6 minutes left.
Okay.
Just because I think we've gone through quite a lot of really heavy but very nutritious information. I think it might be too much for everyone if we go past part 2 and 3. Is there anybody watching who's got any questions for Dr. Hassan? I think we'll probably give it about 5 more minutes, and then Instagram's going to kick us off. And then if everybody's enjoyed it, I think we definitely need to pick up again some point after Eid with part 2 and 3. Probably managed to do them in one session because we did a lot of kind of general chat to the beginning. Guys, if you have any questions around what we've been speaking about today in terms of the initial planning and assessment of these implant courses of treatment, then drop them in down the bottom. I think it's been really good to have you on, man.
Thank you, Jabbar.
You were
Well done on doing this. How did this come to your mind?
The initial page, I was going traveling, and I was going for a couple of weeks with a friend. And this is after university, so I'd failed the finals, but I redid it in, October, November. Foundation training doesn't start till September, so I had a long gap. And then I was, first of all, bored. I saw a medic page doing the same thing. I was like, oh, there's no one for dentistry. So I went ahead and started it. And then my friend, obviously, he said, oh, I'm going to Sri Lanka. He's a teacher. But then I was thinking, well, if I'm going all that way, I want to go to some other places as well. He's only got a week or so, but I don't want to be going on my own to these places. So I kind of made some connections from online via this page.
Wow.
So I managed to meet a few people when I was, first of all, in Kuwait. I met Dr. Raja, who trained in Belfast, but he's in Kuwait now. That's where my grandparents live. So I went to visit him. And then there's some guys in Australia that I managed to visit as well when I was out there. And then kind of the other side of this, not just being, features of people and pages and stuff. I watch a lot of football, but when I was again in university, you couldn't go to the football. So you'd watch it on TV, on your laptop, wherever you are, if you're having to revise. But then there were these YouTube channels that would talk about all these things and have interesting guests on, and they would just talk about the game. And I thought, well, you could do the same thing. It became a bit more like a chat show. So they would do what we would do, and they would talk about football. We would talk about a case. But then they would talk about, oh, how's the grand doing? How's X, Y, Z, and then go off topic a bit as well. So you probably watched yesterday.
So who do you support?
United.
Well, someone has to, so it's okay.
Yeah. But that's where the ideas came from. And then if anyone's watched Joe Rogan, he's got a very good podcast, and I like the idea that you can have a guest on who's very knowledgeable in something and just take away a little bit from them. In all these different areas.
I think, I always tell my younger colleagues, the best two investments you can do in your life, if you have some spare money, either invest in traveling or into education. These are the two things, because you could buy a very expensive watch and within 6 months, it becomes nothing. The novelty of it just expires. While traveling, it will open your horizons, and education will make you always a better person. And you will never regret investing in these 2 points. So yeah, definitely traveling or education.
Yeah, we've got 1.5 minutes left. If we can leave it with Dr. Reza's question, resorbable versus non-resorbable membranes.
That's an amazing question, Dr. Reza. Thank you very much. But I would like, after your kind permission, to leave it till next part, because it's such a big topic and it's related to our next part, which is simultaneous guided bone regeneration or staged approach guided bone regeneration. And that will be the theme of our second part, and we'll be talking about resorbable and non-resorbable. I would like to use this last minute, Jabbar, by thanking everyone joined us or going to listen to us, and wishing everyone, all our dental colleagues all around the world, to stay safe, keep well, and stay connected. It's amazing how, this lockdown, which is a pure negative thing, we managed to get some positive things out of it. And I strongly believe every person, each of us can make that decision, being negative or positive. And every person can make his or her own happiness. So let's all stay positive, stay connected, and I wish you all the best. I will be more than happy to welcome any questions, any inquiries, dental or non-dental, to my Instagram page at any time. And Jabbar, thank you very much.
No worries, guys. Thank you for coming on. We had 4 seconds and we've done it.